On a background of bivalirudin. Currently, guidelines recommend the use of a P2Y12 inhibitor alongside a GP2B3A inhibitor. The combination of the antithrombin agent and the antiplatelet agent is what we use for a PCI, or percutaneous coronary intervention. I felt that this topic was not only relevant to what we've been doing in class, also relevant to being up to date on the new drugs that are coming out in the world of pharmacy. There are three key components to this trial: understanding the role of cangrelor, understanding the role of bivalirudin, and understanding the Champion Phoenix trial. Cangrelor is a potent P2Y12 inhibitor. It's the drug that stops the formation of blood clots in the coronary arteries. It has a rapid onset and offset. Bivalirudin is a direct thrombin inhibitor. It is used for PCI, HIT, and HITTS. Champion Phoenix is a clinical trial comparing cangrelor to clopidogrel standard therapy in subjects who require a PCI. The purpose of this study was to study the effectiveness and the bleeding outcomes of cangrelor in patients in the Champion Phoenix study who underwent a PCI with bivalirudin. This study is a randomized, double-blinded superiority trial. The study took place in 12 countries: USA, Brazil, New Zealand, Thailand, Georgia, Czech Republic, Russia, Australia, Bulgaria, and Germany. The study was published in South Carolina, USA. It was published in 2009. However, it's been a continuous study. The study had 153 sites. Each were a branch of the Clinical Events Committee. Events of death, MI, IDR, or stent thrombosis that happened during the trial in the initial 30 days after randomization were all settled by an independent and blinded Clinical Events Committee. The inclusions of this trial were patients who were 18 years of age or older who required PCI for a STEMI, NSTEMI, or stable angina, also who had not received a P2Y12 or G2B3A inhibitor were eligible. The exclusion patients were those who applied prior to randomization, received a P2Y12 inhibitor at any time in the 7 days preceding randomization, patients who took actifabate or tirofiban usage within 12 hours preceding randomization, patients who took abciximab usage within 7 days preceding randomization, patients on fibrinolytic therapy in the 12 hours preceding randomization, or patients at risk of increased bleeding. The subjects were part of a modified intention to treat, or MITT study population of 10,942 patients. The patients were male or non-pregnant female, at least 18 years of age as stated before. Of those 10,942 patients, our focus is going to be on the 2,059 patients who got bivalirudin as their procedural anticoagulant. The primary efficacy endpoint was comprised of a rate of death from any reason, whether it be MI or IDR or stent thrombosis in the 48 hours after randomization. The secondary efficacy endpoint was the occurrence of a stent thrombosis at 48 hours containing both academic research consortium defined and intraprocedural stent thrombosis. The follow-up was conducted through 1 year. Patients were followed through 30 days each. The duration of the study was 2 years long, with multiple studies generating new hypotheses, and it's been ongoing for about 4 years now. This sub-study is included in that Phoenix trial study. The population, as stated before, is 10,942, part of the Phoenix study. We're going to be focusing on the three subsets: 2,059 patients who are receiving bivalirudin, and that 18.8% that you're seeing is actually 18.8% of the Phoenix patient trial. We have a subgroup number 2, which is comprised of 1,014 patients taking cangrelor, and then we have our final subset of patients who is taking the clopidogrel, and that's consistent of 1,045 patients. Now for the meat of the trial, the statistical analysis. The investigations from the statistical analysis is from information from the MITT Associates, which involve patients who experienced the PCI and got the study drug. Many variables are summarized as median and quartile or mean standard deviation. And analyzed utilizing the student t-test or Wilcox rank sum test, variables are displayed as a percentage and looked at by the chi-square or Fisher-Precise test as suitable. Communication between the treatment and the distinctive subgroups on endpoint event was tested using the Breslow-Day technique. Time to occasion curve were built utilizing the Kaplan-Meier system and compared to log rank test. No conformity was made in the different correlations. All the figures in the analysis I have up is measurable. At 40 hours, we have the primary endpoint of death, myocardial infarction, ischemia, revascularization, stent thrombosis, which the results showed it was lower with cangrelor versus clopidogrel. Cangrelor had 48 while clopidogrel had 70, and I have an odd ratio up here as well. The death was, similar in both arms. The incidence of myocardial infarction was reduced by cangrelor having 37, clopidogrel having 59. Once again, I have the odds ratio up there. Let's scroll down to where we have cangrelor showing a non-significant trend towards less stent thrombosis, which is pretty significant. Cangrelor having 0.7 and clopidogrel having 1.4%. Now we're going to go to the bottom where it shows the bleeding incidence, which shows that it's similar in both arms. So that's very important because if we go back to the beginning, one of the main goals was to prove that cangrelor was better in this incidence, and during our statistical analysis we see that bleeding was similar in both arms, with cangrelor having 0.2% and clopidogrel having the same 0.2%. Efficacy and safety results were consistent in all patients with stable angina and ST segment elevation. Generally speaking, the groups were all around adjusted. There was somewhat less patients with expanded biomarkers in the cangrelor group. PCI was most commonly performed in patients with stable angina. As for the results I've seen, the baseline characteristics show that in patients accepting bivalirudin, cangrelor brought on about a lower reoccurrence of MI and intense stent thrombosis compared to clopidogrel without increasing major bleeding or blood transfusions. Now, let's get that wording correct, all because it didn't increase the incidence of bleeding. It doesn't mean that it lowered it. Another result showed, the primary endpoint being that out of all the patients treated with bivalirudin, the use of cangrelor was associated with significant reduction in the risk of primary efficacy endpoints of death, including MI, IDR, or stent thrombosis at 48 hours compared to that of clopidogrel. Now, I highlighted the point that we need to know that the number needed to treat with cangrelor to prevent one primary endpoint was 50. The number needed to rescue glycoprotein 2B3A inhibitors was also lower. And when you look at the secondary endpoint, we have a few more highlights. The rate of stent thrombosis at 48 hours was non-significantly lower in cangrelor. Stent thrombosis appeared to be lower with cangrelor in the first 2 hours compared to that with clopidogrel. Now, these are tiny improvements. We also have MI, which was reduced with cangrelor, as stated before, versus clopidogrel. A few more statistics on that. We have a few adverse events, but nothing noteworthy in contrast to the Gusto, which showed, of course, the bleeding. The author's conclusion of this sub-study is consistent with those the Champion Phoenix. In this predetermined subgroup investigation, patients accepting bivalirudin cangrelor compared to clopidogrel showed a decrease in the essential composite result of death, MIIDR, stent thrombosis, at 48 hours after randomization. There was a decrease in MI and composite of death caused by MI, despite the fact that it's not statistically significant due to low frequency of stent thrombosis, diminishment of about 50% in the quantity of incidence of stent thrombosis with the use of cangrelor. This impact was particularly noticeable within the first few hours. The lessening of essential endpoints of cangrelor was steady over the diverse clinical groups of patients receiving a PCI. My critique. Cangrelor offers an alluring risk profile when utilized with bivalirudin. It's the new kid on the block. Bivalirudin and cangrelor are two IV medications, one for anticoagulation and the other for antiplatelet treatment, both having fast onset and activity. It makes it flawless for the use of a PCI. These impacts are particularly required for reperfusion in acute patients. For example, patients with NSTEMI, STEMI. The short half-lives and great resistance of the two medication adds on to the allure of their profile. Now for the weaknesses. This study is predetermined and very premeditated. They have this subgroup they're examining with this randomized trial, and bivalirudin isn't even randomized. In the capacity, our discoveries ought to be considered speculation creating, or maybe I should say generating a hypothesis for future situations and future studies. It is conceivable that the absence of bleeding in cangrelor may identify with a type 2 error because the low number of patients treating with bivalirudin. I mean, we had over 10,000 patients and we only used 2,000. The more up-to-date P2Y12 inhibitors like ticagrelor and pasogrel were not even used in this study. And honestly, I feel like if you're going to do a study, you should compare it to all drugs in that class, to be fair, especially in this case where there's so few. They could have at least mentioned them, and they didn't mention them at all, which was quite disappointing. Although the study was complete, this felt like an incomplete study. So in summary, this randomized double-blinded superior trial was conducted in order to use a previous study, the Champion Phoenix, to further compare the efficacies of cangrelor bivalirudin and clopidogrel bivalirudin. Out of 11,145 patients in the Champion Phoenix trial, 203 did not even experience a PCI or get any of the study medication. So that brought down the MITT study population to about 10,942 patients. Bivalirudin, of course, utilizing only 2,059 of these patients, making it only 18.8% of the Phoenix trial. So great news for the world of pharmacy. As of June 22nd, 2015, the FDA affirmed cangrel or cangrelor in a clinical trial, which we now know to be the Phoenix trial. Cangrelor and clopidogrel was used in more than 10,000 numbers. Cangrelor significantly diminished the event of heart attack. It was found that the event of serious bleeding was low, yet more regular with cangrelor versus clopidogrel. So roughly 1 in every 170 cangrelor patients had incidents of bleeding versus 1 in 275 clopidogrel patients. It goes back to what I was saying. All because it doesn't make it worse, doesn't make it better. Cost also plays a major role in patients hospitalized. Cangrelor is actually cheaper. It's $10,308 versus clopidogrel, which is $10,738. That's a number savings of $430. Another highlight I wanted to point out was the cost of receiving both the combination cangrelor bivalirudin which was $11,139 versus clopidogrel by valirudin, which cost $11,661, which is a savings of $522. Those numbers alone, savings of 430, savings of 522, it's enough to take a second look at cangrelor, but I would like to see more studies before trying to recommend that over clopidogrel, or before recommending it over clopidogrel by valirudin. Although clopidogrel requires testing to see if someone can even begin to take it, I think it's worth a shot.